working at Barrier International Hospital, Rawalpindi, where this research was primarily conducted. Role of regional anesthesia in pain management in sternotomy patients undergoing cardiac surgery. So, this will be the outline of my study. Introduction, then rationale and background. Then I will discuss the objectives of my study, materials and methods, results, and finally I will discuss the conclusion. Background and rationale. Basically, in every cardiac surgery, sternotomy is performed, which is a very painful procedure. And this pain doesn't only causes intraoperative complications, but leads to various post-operative complications. The intraoperative complications include, because of pain, there is increased sympathetic discharge, and there is increased tachycardia, hypertension, increased oxygen load, increased myocardial oxygen demand. That may lead to myocardial infarction and myocardial ischemia. Similarly, in the post-operative period, this pain, because of this pain of sternotomy, the patient can't breathe properly, and it leads to decreased inspiratory efforts, decreased sputum clearance, and basal atelectasis, and ultimately pneumonia and prolonged ICU stay. So the pain has been a great challenge for anesthetists, and various modalities have been used in the past. Like opioids have been the mainstay of the treatment, but with the passage of time, regional blocks have gained popularity, and now they are being used in different parts of the world to manage the pain of sternotomy and cardiac surgery patients. So my objectives of study to compare the efficacy of opioids versus regional blocks for pain management in cardiac surgery undergoing sternotomy. And my secondary objective was to measure the pulmonary function test in these two groups. This was a prospective study and a randomized controlled trial. The sample size was of 50 patients that was calculated using WHO calculator. And there were two groups, each group containing 25 patients. One group receiving conventional opioid-based analgesia that we selected for all study as fentanyl, and the second group was of regional block group in which we selected parasternal intercostal block for management of pain. Now this is a technique for parasternal intercostal block. Various actually regional blocks are being used for pain management in cardiac surgery. That includes thoracic epidurals, paravertebral blocks, erector spiny plane block, serratus anterior plane block, and paravertebral intercostal blocks. But this has gained popularity because of compatibility. It can be performed easily just before extubation on the bedside, and because of the usage of ultrasound, the rate of complication is very few. I mean, you can see the pleura and the complication like pneumothorax and intravascular injection of local anesthetics. These complications are reduced. So here you can see in the diagram above, first of all skin, then pectoralis major muscle, then comes external and internal intercostal muscles. And before that layer, the bundle of neurovascular fibers run at the lower margin of upper rib, and this is your target site of local anesthetic agent that we choose ropivacaine 0.25% in our study that was injected 10 ml bilaterally on each side, 2 cm away from the sternum. Coming towards exclusion and inclusion criteria, the patients 20 to 60 years of age undergoing coronary artery bypass grafting and valve replacement surgery were selected, and to avoid confounding, the patients with pre-existing obstructive and restricted lung disease, the patients having opioid dependency and psychosomatic disorders were excluded. Now, what were our parameters that we assessed in our study? It was VAS score, visual analog score, then opioid requirement. To assess the secondary variables of our study, we assessed peak expiratory flow rate, incentives spirometry capacity, ICU stay, post-operative nausea and vomiting frequency, and the rate of complications. Now, this is the visual analog score that is used frequently for assessment of pain in patients. Here is a scale of 0 to 10. 0 to 3 is a mild pain score, 3 to 6 is a moderate, and then 7 to 10 is a severe or very severe. And you can actually teach the patient before that this is how you can rate your pain, and you can judge on the basis of facial expressions of the patient as well. Now, in our study, what we found, what were the results? The parasternal block group has used. The problem with opioid is that they have got various side effects ranging from nausea and vomiting to gastroparesis, increased level of sedation, and further decreased respiratory drive. These further complicate the things. The incidence of post-operative nausea and vomiting was reduced from 45 to 15% in block group. And then the secondary parameters, FEV1 was 2.3 in block group, 1.8 in control group. Peak expiratory flow rate that was assessed by using peak flow meter was 350 liter per minute in block group and 280 liter per minute in control group. That again shows that pulmonary functions are improved in block group. And incentive spirometric capacity was round about 2100 ml in block group and 1500 ml in control group. That again shows the better compliance of the lungs with the parasternal intercostal block. And this is the graphical tabulated form of the previous results. And this is the ultimate thing that we got from our study. ICU stay. ICU stay was reduced from average 48 to 36 hours in block group. Conclusion: parasternal interblock provides better and significant pain relief in post-operative patients of cardiac surgery. They decrease the chance of respiratory infections like pneumonia, and further research is needed to incorporate it as recommendation for protocols of post-operative management of cardiac surgery. Thank you.